Case presentation, a 36-year-old previously healthy woman presented with a 5-month history of progressive neurological decline, early symptoms. Her illness began insidiously with vertigo and imbalance while walking. She described a spinning sensation and progressive unsteadiness. Family members observed that she consistently veered and fell toward one side. Initially, this was attributed to a peripheral vestibular disorder. Progression over the following weeks. Her gait instability worsened significantly, and she required assistance to walk. Soon after, cognitive symptoms emerged, including forgetfulness, poor concentration, impaired judgment, and difficulty performing routine tasks. By the 3rd to 4th month, her cognitive decline accelerated. She developed severe memory impairment, behavioral changes, and loss of functional independence. Neurological examination. On examination, multiple neurological systems were involved. Cerebellar signs and extrapyramidal signs noted. Severe impairment of memory and executive function. Disorientation and poor attention. The combination of rapidly progressive dementia, cerebellar dysfunction, and Parkinsonian features suggested a diffuse central nervous system process involving both cortical and subcortical structures. Differential diagnosis and diagnostic reasoning. Given the patient's age and subacute progression, a structured diagnostic approach was undertaken. 1. Autoimmune encephalitis, initial leading diagnosis. Autoimmune encephalitis was strongly suspected initially because it commonly presents in young adults with subacute cognitive decline and neuropsychiatric symptoms. These disorders can present with cognitive dysfunction, movement disorders, seizures, and cerebellar features. 2. Wilson disease. Wilson disease was considered due to young age, tremor, rigidity, cognitive decline. 3. Infectious causes. Rapid cognitive decline necessitated exclusion of infections such as HIV-associated neurocognitive disorder, neurosyphilis, viral encephalitis, progressive multifocal leukoencephalopathy. 4. Metabolic and mitochondrial disorders. Metabolic and mitochondrial diseases were considered because they can present with multisystem neurological involvement. 5. Neurodegenerative disorders. Classical neurodegenerative diseases were also considered. Multiple system atrophy, progressive supranuclear palsy, corticobasal degeneration, dementia with Lewy bodies. Critical turning point, MRI findings. MRI brain played a decisive role in diagnosis findings. Diffusion-weighted imaging showed cortical ribboning, hyperintensity in the caudate nucleus and putamen, basal ganglia. These findings are highly suggestive of prion disease. The combination of cortical and basal ganglia diffusion restriction is one of the most specific imaging patterns for sporadic Creutzfeldt-Jakob disease.